So you might be thinking that treating MDR is very, very easy, but it is not. There is a lot of dedication, efforts, and the commitment which he is having, it's required. So now the topic is open for the discussion.
India did a lot of mistakes in treating their patients with TB. This was right from the beginning when we started DOTS. When the DOTS, we started only one drug for a failing regimen. We are trying to follow INH prophylactic therapy for patients with HIV and preventing that. The data coming from South Africa and African countries where there was significant decrease in terms of mortality, where even though there was no TB, just adding an INH and early treatment of ART helped those patients with mortality. I do not know the ratio of the primary INH resistance in Africa, but probably in India it may be about 10% or more. Probably people may be able to tell me more. But in a situation like that, do we think that by adding INH single drug therapy will be creating more drug resistance even to INH further and further? Could be answered by the Dr. Sachdev and maybe then Dr. Raju Suman.
So, the levels of INH drug resistance which are seen on a programmatic basis, I mean, which was, we were doing drug susceptibility on phenotypic methods about few years back. Now we have switched to molecular DST. So, based on the little data which is available in the year 2007, 8, 9, the levels of INH drug resistance in the primary INH drug resistance is about, again, 10%. It varies between 10 to 15% or so. Having said that, that issue remains a challenge, whether the patients who are having TB and when you put them on INH prophylactic therapy, are you likely to generate more resistance or not? That issue is not solved as yet, but yes, the IPT remains one of the recommendations the world over, and our INH, primary INH resistance are not very different from most of the other countries. Still, the last word on IPT is not out. How successful the IPT is, what should be the ideal duration of IPT, is 6 months enough to protect, how long will it protect? But what has been seen is that 6 months of IPT at least gives you some protection for about 2 to 5 years, and it has shown a decline in TB incidence in countries where it has been implemented. The last word on IPT is still not out. The research needs to be carried out, and South Africa is one of the countries which is leading this research. Yes, please.
Dr. Soman first.
Yeah, although, I mean, I entirely agree that the rates of monoresistance to INH are roughly 10%. Here we are dealing with a person who's not having an actively multiplying bacterial population. Okay, so it may not be that important, because this 10% is in patients who have full-blown disease, and therefore the chances of those people having latently infected ones with INH resistance becomes somewhat less. The other major problem, as I see it, is you hardly have a patient who's not got active TB. You know, at least I can't remember too many patients who have presented, who have come to me for HIV and do not have active TB at that stage. And therefore, in my practice, to use IPT has become a major challenge. Now, those people, like they said that they were going to train the medical doctors, the medical officers and so on for implementing this. See, it becomes even more important responsibility of the doctor to see that he has to change when there is an evidence of active disease. You put somebody on IPT, he comes, you have to very, very closely monitor whether he's getting an active TB disease somewhere, because otherwise it's a sin to continue with that active IPT while he has already developed a reactivation disease somewhere. So these challenges are extremely important, and all these things we need to carefully consider whether when we sort of jump onto this IPT.
Yeah, so basically my question was the same thing, that in a country like India, just following a data from South Africa where we had a good response to IPT. Whether India should be taking up the lead in taking this, because see, this was even previously being done for cancer patients, for other patients where immunosuppressive therapies were being given and they were given single drug INH prophylaxis. But now most people who are doing transplant program on a regular basis don't put them on a INH prophylaxis. Most patients who treat their patients with immunological disorders don't put them on INH prophylaxis. So whether here is going to be a huge, large population where we are going to put them on an INH prophylactic therapy, is it a really good idea, or whether we should really be waiting and putting it?
Again, I'm saying the same thing. If you ask me, there won't be so many patients like this.
So can I
There
add?
will be, most patients will have active TB disease when they come to medical attention.
So,
So the chances of, that's what I feel. Anyway, let
So
Dr. Sajjan.
let me add, the data from program is different, the data coming from tertiary care institutions. There is a data and studies available. The 4 symptom screen which the program uses is almost 95% more than sensitive and specific. So if you not have one of those 4 symptoms, there is 98% chances that you will not be having tuberculosis. So IPT is only offered once you rule out active TB. So the data coming from program is when you screen HIV positive from patients on those symptoms, around 5% of them report those symptoms on any day of screening. Of those 5% who report with symptoms when they are tested for HIV, for tuberculosis by any method, around 1/5 of them will be positive for TB. So it's about 1% who actually turn up positive for TB at any point of time. They are at risk at all points of time. So that screening has to continue continuously. So the data from tertiary care institutions and the what we see in the community is much different. Dr. Khapade can add on more. Yeah.
Recently, the WHO has given the recommendations for this particular thing, IPT. That is the rifabutin plus INH. That is a 6-week therapy, and that is not a 6 month like the INH. We are giving the single drug for IPT as a 6 month for children and HIV patient as a IPT. But that is really a very large, because most of the people for 6 months is just like a therapy itself. So it is very difficult to, now the WHO have come with recommendations for the rifabutin plus INH for only for 6 week doses, and that is not a daily doses also, once in a week. So that type of combination of therapy which is already been recommended by WHO, and that is really a very good for immunoprophylactic, IPT purpose.
Sir, first of all, thank you for such a wonderful presentation about tuberculosis from all the experts on the panel. Here, more than a question, I have a suggestion that many doctors, the doctors who are in the field of HIV, they know, they have a little better knowledge about treating tuberculosis, but in general, the proper diagnosis of tuberculosis, we seem to be lacking in the general physicians community, general doctors community, which is the reason, as Dr. Suman has said, that though we had good, efficient regimen, we could not control this disease as it is expected. So having the national authorities on board, it is a humble request to strengthen the public-private partnership and education of the private sector's doctors in terms of diagnosing and treating the tuberculosis.
Thank you. Love, you want to comment? Thank you. A pertinent point, and I think also in terms of the national strategies on TB, we have a lot of learnings also to do towards HIV on this public-private sector partnership that should be there. So I thank Dr. Sunil, Dr. Mehta, Dr. Sachdeva, and Dr. Rajiv for their presentation. Maybe we can have the...
Yeah, I request the chairpersons to kindly felicitate the speakers. Dr. Preeti Mehta, Dr. K. Sachdeva, Dr. Raji Soman.